Hey everyone, and welcome. Today, we're diving deep into something that's absolutely central to our practice, anesthetic adjuncts. Now, think of these not as just some random list of drugs, but as your own precision toolkit. Mastering this toolkit is really what takes us from being good at our jobs to being great, allowing us to get ahead of challenges and make sure our patients have the best, safest experience possible. So here's what we're going to cover today. We've built this whole explainer around the very real challenges we all face in the OR day in and day out. We'll start by laying out our toolkit. Then we'll talk about guarding the airway, tackling that dreaded post-op nausea, fine-tuning pain control and sedation, and finally, we'll get into the crucial art of reversal. All right, let's jump right in. We all know the big three of anesthesia: amnesia, analgesia, and akinesia. But honestly, the real art, the real magic, that happens with the adjuncts. These are the drugs that let us stay proactive, that help us prevent complications before they even start, and that ensure a smooth recovery. This is where we truly practice the art of anesthesia. Okay, so first up is something that, let's be honest, every anesthetist respects and, fears: aspiration of gastric contents. This is a huge deal, and our adjuncts are literally our first line of defense. Because while securing the airway is job number one, making sure nothing from the stomach gets into it in the first place is just as critical. But before we get to the solutions, let's really define the problem. What are the critical numbers that can turn a potential risk into an absolute disaster? There are two numbers here that you should have burned into your brain. Okay, number one, a gastric pH less than 2.5. And I'm not talking just a little acidic. This stuff is incredibly caustic to the delicate lung tissue. We're talking about an immediate and severe chemical burn that kicks off a devastating inflammatory response. So it's not just food in the lungs, it's acid. And the other magic number, a gastric volume over 25 milliliters. Why does this matter? Well, more volume means that acid can spread farther, damaging way more lung tissue. You put that low pH and high volume together, and you've got a recipe for a total catastrophe. So who should be on your high alert radar? Think of this as your mental checklist every time you see a patient. Anyone with a full stomach is an obvious one, right? Whether they just ate or they have an obstruction. Then you add in anyone with increased pressure in their abdomen, so obesity, pregnancy, and of course a history of GERD or any emergency case. Those should be setting off major alarm bells. So how do we fight back? Let's open up that toolkit. This table breaks it down nicely. You've got your H2 blockers, like Ranitidine, which are fantastic for bringing down acidity. Metoclopramide works differently. It actually tightens up the lower esophageal sphincter, making that barrier stronger. And then you have your non-particulate antacids for an instant pH boost, though you got to remember they can increase the total volume. The real skill is knowing which one or which combo is right for your patient. But listen, it's not all about pharmacology, right? Your technique is just as important, and that's where rapid sequence induction, or RSI, is our absolute go-to. First, we pre-oxygenate to load up the lungs with oxygen, buying ourselves time. Then, cricoid pressure to physically block off the esophagus. We push our induction agent and paralytic, and then, boom, we intubate right away. No bagging in between. It's all about securing that airway as fast and as safely as humanly possible. And that's really the bottom line for this whole section. It's that combo, smart drug choices plus a flawless RSI technique, that is our most powerful weapon against the terrible consequences of aspiration. Okay, airways secured, high five, but our job is far from over. The next big hurdle we face constantly is postoperative nausea and vomiting, or PONV. For a lot of patients, this is the worst part of the whole experience, worse than the pain. And it's not just about comfort. Severe PONV can cause real problems. So just like with aspiration, step one is spotting the at-risk patient. Some factors are huge predictors, like being female or having a history of PONV or motion sickness. And here's a weird one, right? Non-smokers. It's totally counterintuitive, but it seems chronic smoking kind of dulls that nausea trigger zone in the brain. Then, of course, you have our drugs, volatiles, nitrous, opioids, and certain types of surgery that are big culprits. So what's in our arsenal for PNV? Let's compare two of the heavy hitters. You've got ondansetron, a 5-HT3 antagonist. It's a total go-to for most of us, and it works really well. The thing you have to keep in the back of your mind is its potential to prolong the QT interval on an EKG. On the other side, you've got dexamethasone. We're not 100% sure how it works, but it's probably its anti-inflammatory effect. And man, it's a game changer for PNV. The trade-off?
You got to be careful in diabetic patients because of the risk of hyperglycemia. And listen, if you take one clinical pearl away about PONV, let it be this. Do not sleep on dexamethasone. The data shows it's just as effective as ondansetron. And the best part? It's most effective when you give it right at the start of the case, at induction. It is a simple, cheap, and incredibly powerful tool to have in your back pocket. Okay, let's shift gears and level up our game now. Let's talk about tailoring patient comfort. We're moving beyond the basics here and into a more multimodal approach to pain management and sedation, using some adjuncts that have really unique advantages. All right, check these two out. Very different drugs, but both are incredibly valuable. First up, Ketorolac. It's a potent NSAID that gives us fantastic, opioid-sparing pain relief, but you have to respect it. Always be thinking about bleeding risk and potential kidney issues. Then you have dexmedetomine. Its superpower? It provides sedation without knocking out the patient's respiratory drive. But you have to keep a close watch on the monitor because bradycardia and hypotension can definitely happen. And that's why dexmedetomidine is so cool. It fills this really specific, super important niche. Think about those awake fiber optic intubations where you need a patient who is calm and cooperative but still breathing on their own, or for light sedation in the ICU. It's just invaluable for those situations. And now, for the grand finale. This is it, the final act, and you could argue it's the most critical part of the whole show, the emergence. Getting our patients awake, comfortable, and breathing safely, that's the whole point, right? This is all about mastering the art of reversal. Okay, picture this. You're in the recovery room, your patient is way too sleepy, the respiratory rate is in the single digits. The very first question that should pop into your head is, what did they get? Was it an opioid or was it a benzodiazepine? Because the answer to that question completely changes what you do next. And this is where you need to know your reversal agents cold. For opioids, you reach for Naloxone. It's a competitive antagonist. It literally kicks the opioids off their receptors. For benzos, it's flumazenil. It does the exact same thing but for the GABA A receptor. But, and this is a huge but, you have to be careful. Slam in too much Naloxone and you've just wiped out their pain control, which can cause a huge, dangerous spike in heart rate and blood pressure. And give flumazenil to someone who's dependent on benzos, you could trigger a life-threatening seizure. This is so important. I have to say it again. When you're reversing opioids with Naloxone, the goal isn't to jolt the patient awake in screaming pain. The goal is just to get them breathing again. So what do? You dilute it. You give tiny incremental doses, just enough to nudge their respiratory drive back online without yanking away all their analgesia. Titrate to effect. So, there it is, your toolkit for safer anesthesia. From dodging aspiration and nausea to fine-tuning comfort and absolutely sticking the landing with a safe reversal, these adjuncts are the essential tools that elevate our practice and keep our patients safe and happy. All right, that's our deep dive for today. I'm going to leave you with a question for your very next case. When you're prepping, look at your patient, think about the surgery they're about to have, and ask yourself, which tool from this explainer can I use today to get ahead of a problem before it even thinks about starting? Thanks for joining me.